kidney combo. This is a pancreas kidney transplant combo, and ultrasound was normal. And this is a study that it was my first time reading the study. Any guess from anyone as to what this is?
I must say the angio looks gorgeous.
Isn't it beautiful? I mean, it's like super gorgeous.
Super gorgeous, agreed.
Well, what kind of an angio is this?
Nelly, what technique is this?
Yes, what is this technique here? This is ferumoxytol.
Wow.
We just started doing this. Ghaneh set up the protocol here. And I read this. This was my first ferumoxytol study, and I had to. So Ghaneh helped me through this. I mean, the vascular anatomy is just phenomenal,
Indeed.
right? And
yeah.
And
can you walk us through the protocol a little bit? Tell us more.
No, I told Ghaneh to show up, but he's not here. But so this was the initial study that we did because there was concern. So I mean, ferumoxytol is it's iron, right? It's just iron, and it's like a vascular agent, and it stays in the body for a long time. 6 hours, I think, is a half-life, and it's FDA approved for like treatment of anemia. So this is an off-label use. And it's really great in our, transplant patients where there's still some concern, at least from the providers, about just gadolinium, even though we know that there's like totally safe in with type 2 agents. But I think it's actually better. I mean, for vascular anatomy, it's better than type 2 agents, right? And you just get a perfect shot every time because ferumoxytol is in the blood for so long. So Ghaneh said that the acquisition, this is a 3D acquisition. So it's amazing because you can slice and dice this baby and it looks awesome. Where's my, here. And you just get these beautiful 3D images, right? Because you have, is it working? I'm trying to, here, yeah. So you can take this and you can 3D slices and you get coronal, sagittal. You can reformat it any way you want. He said the acquisition is pretty long though. It's like 15 minutes. So anyways, it's great because we only get a handful of sequence and you just slice and dice. So this was done initially first day, and we didn't really see the veins very well. So we got a repeat the next day, which is what I read. So we didn't have to repeat. We give ferumoxytol because it was in the system. So we just acquired this the next day, and it's amazing. Look, so right now this is a pancreas transplant. So the pancreatic head is here. The tail is cranial right here. And what we see here is a lot of things, actually. Like I said, the ultrasound was negative. But if you look at the vascular anatomy, so here is the aorta, and then the vena cava is a little kind of thin. I mean, kind of compressed from all the edema. Here's the Y graft, and there's a stenosis here on the Y graft, right? So that was amazing. And then the other thing, so that's the artery, and then the vein is here, and there's a non-occlusive thrombus here, right there along the wall. There's a little bit of a sliver left. And when you follow this, so there's going to the head is fine, but there's a branch going to the neck, and then this one goes to the tail. That's all occluded. So that none of that we didn't see the day before because he played around with some of the parameters to increase the soft tissue resolution, and then, like I said, the ultrasound was negative. So we see thrombosis of as the vein supplying the tail. So that's the SMV, the donor SMV with the Y graft. So let me see. I want to show you drag over. I
Yeah, quick question, Nelly.
Yeah.
Ahmad wants to know if ferraheme is the same as ferumoxytol injection.
yes,
It's the
yes,
same, right? Yeah.
yes, yeah. So I'm gonna drag my notes over so you can see some of the teaching points from this case. Okay. Can you see my screen?
Yes.
Okay. So, like I said, Ghaneh like helped me through this case because this was my first ferraheme study. So the pancreas, the pancreatic head is, you know, caudal, and then the tail, and then they take a Y graft. So there's a Y graft that's harvested, and then they attach that. So the anatomy is kind of interesting, and I think so. In this case, the vein supplying the tail was completely thrombosed, and there was a narrowing in the one of the Y graft arm of the arterial supply. In addition, on the renal transplant, there's also a stenosis. So here, this is, let's see, here's the artery. Patient has an accessory renal artery, but this is really not very good, actually. Let me do this one better. So here you can see the anastomotic narrowing, or not the anastomotic, but just this tight stricture really well on the main renal artery, just just downstream of like the anastomosis. And then this is the accessory renal artery, and that looks great. So yeah, this is an example of a ferraheme study. The vascular anatomy is just phenomenal. I mean, super useful in this case for pancreas renal transplant. And, you know, we're able to clearly see the venous and the arterial anatomy, and, you know, kind of just give a very accurate picture of what's going on compared to what we had before, which was like ultrasound and MR with type 2 CAD.
No, this is beautiful. Are there any contraindications for this study?
Okay, so sort of what I think if they have allergies, just not I think anyone can get it. We reserve this typically for patients, you know, like here at least the population that we're looking, we've been doing this for is transplant patients, primarily. That's and what else? I don't think there's any, I mean, aside from, you know, allergies and other stuff, I don't think there's contraindication because it's just.
And in some ways, this population is also anemic. So I guess giving them iron doesn't
helpful,
right?
Yeah, right, exactly. It's, I mean, I think there's considerations in administering it because it has to be done really slow, because then they like they just, if you do it too fast, I guess they get certain physiologic reactions. So there's like specifics, and next time I'm gonna ask Ghaneh. I told him to come and talk about this, because he has very deep insights, but I think he's probably busy right now clinically, so couldn't join.
But this is great. This is a terrific thing to share. Thank you. Victoria, are you back? Do you want to?
Yes, I'm back. We had a stat request for the stat read. Can you hear me?
Yes, yes. Go ahead. Yeah.
Let's see. Just want to make sure that I'm not flashing any patient.
Do you want me to pause? I can pause for a minute.
No. Let's see. Share screen. Oh, actually, you know, yeah, do pause. Just okay. So, you know, I'm going to stick with livers because that's what I like. So this is an interesting case, you know, a very heterogeneous kind of ugly looking liver. And if we were just relying on here, on the, on the contrast study, it's hard to judge because everything is so heterogeneous. Maybe there's something here, but, you know, it's unclear what this is similar to that. So just if we were looking at the, you know, this is arterial and delayed images, it's difficult to judge whether or not it's real. And this is where the ancillary features kind of can be helpful So if we look at the in and out of phase images, you can notice that on the on this one, on the wait a second, on the in phase, right, on the second echo, I can't turn on the outline, but this is the second echo, so this is the in phase. You can see that there's slight signal loss in the liver, indicating that there's iron deposition, and the lesion stands out on this sequence as compared to the shorter echo. So there's so this is called lesional iron sparing. So that confirms that this area of enhancement that we saw on arterial phase and delayed phases is a real lesion. We also can see the same thing on T2. Notice that the lesion is mildly T2 hyperintense, similar to, somewhat to the spleen, and same thing on diffusion. The background of the liver is very suppressed because of iron, but the lesion stands out. So this is, actually probably more manifestation of iron sparing than restricted diffusion, but it's really doesn't matter because we've already used the ancillary features to confirm that the lesion is real, right? So we don't have to worry about that. We're just, overcalling an area of parenchyma that's just too heterogeneous. So this is a real Leyrat's 5 lesion, and it's just an example how ancillary features can be quite helpful sometimes. Any questions?
Very nice example. Comment, no questions. And then on did it show the classic enhancement pattern as well? Was it like washing out? And
so this is it, right? So you have this enhancement. Let's see, arrow, right? So this enhancement, right? Again, if without definitively knowing that you're looking at the liver, you can argue that, okay, well, this kind of sort of looks like similar to that, and is it real enhancement? So just based on this image, you could dismiss this whole area as just, like an area of heterogeneity. Here on the portal venous phase, you see that it is ill-defined and it is hyper enhancing, and that area truly corresponds to, to the T2 hyperintensity.
Right.
So that's the washout. So this lesion did have enhancement and washout. So this is a Leyrat's 5. It's just because of liver heterogeneity, patient has advanced cirrhosis. Sometimes, that can be a little challenging. And so this is an example where ancillary features kind of help you to be more definitive.
Do you have subtraction?
We do have subtractions. And indeed, right, so this is, you can see that this is a subtraction, right? It doesn't give you much more, it's not as helpful, it doesn't give you any more information than with that because it wasn't very T1 hyperintense. Subtraction is really helpful when you start out with intrinsic T1 hyperintensity, which wasn't here. So, but so on subtractions, we sort of see the same finding that the lesion is, so somewhat hyperenhancing, and then you have this ill-defined area of washout. So it's without, if we didn't pay attention to the other sequences, this is a very easily dismissible area, but all the other sequences confirm that this is a real lesion, space occupying mass, so then we can be more comfortable calling it.
great example, because
I know some of my colleagues
Yes.
don't believe in ancillary features, but this is an example where they're actually very, very helpful.
Yeah.
It's not that they don't believe, but they question the utility.
I believe you, Victoria.
So this was a really one of the scariest cases I've seen. So I guess oh shoot, hold on. I don't understand why. Why overlay showed up, but that's okay. So this, I started out this patient, right? This is how I got involved with this patient. So I was reading the CT, follow-up CT. Patient had Y90, had some sort of post-treatment effect in the liver. Liver is very cirrhotic. Patient has advanced cirrhosis, kind of has areas here, like in the left hepatic lobe, ill-defined areas which don't quite enhance. So some of it was post-treatment. And then this was the first scan where the patient developed multiple peritoneal nodules. So this patient had, progressed with peritoneal carcinomatosis. So, I was curious what the path was, and the path was intrahepatic cholangio. So I decided to look back and see what it looked like off the get-go. And this is the most subtlest intrahepatic cholangio I've ever seen in my life, because this is pretty much what we see. I've gone through all the sequences up and down, but this very subtle kind of ill-defined area of enhancement is all that we see in this very aggressive tumor. You can see that because of its unfortunate location, it's it's very easily can be dismissed as maybe just like sometimes you see weird areas at the edges. So you can see here, this is the delayed image again, very easily dismissible as nothing, or just, like some funky stuff at the edge.
What
and
was the
then
Y90 for? Like what did it?
Y90 was for treatment. So they sampled it under sono, and actually, interestingly, on sono, this mass is much more easily identifiable. Let me just pull up ultrasound for 1 second.
So he had that lesion. It was seen under ultrasound, and then
No,
Y90.
No, the lesion was actually seen. This is an outside study, and the lesion was picked up, which is incredibly impressive to me, because again, it is super subtle. Because of its, first of all, its imaging characteristics are not very obvious on the MR, but also its location is such that it's very easily dismissed, even if you notice it. Like, it's hard to notice, I think. But even if you notice, you can probably go back and forth and say, well, I don't know if it's real because of its location. If I recall correctly, there was, so I don't, these were MRs from outside studies, so I don't know how they were called, if they were called immediately, they were called correctly as a lesion, or they were questioned. I think this was the original lesion, very, very subtle, and then the follow-up of this lesion looked like this about 8 months later. So it's a little more obvious, or a lot more obvious, actually. Right? You can, this one's much more obvious in terms of that it's not just like a,
It has the nice rim
right
enhancement.
But somebody called it on the one that I showed you, in the very, very subtle. I think
It was
they asked.
reviewed at tumor board, Victoria.
Huh?
It was reviewed at tumor board, and I remember.
This one is callable, I think. The first one, the initial one, was super subtle. If it was truly called, I'm incredibly impressed. But anyway, but here's what the sono looks like. Let me just carefully not flash the patient's identifiers there. You can see that it's much more obvious on the sono. I mean, it's clearly a true lesion. And then it was sampled under sono, and this was a cholangio. But again, this was like the subtlest of cholangios I've seen ever. Usually they're much less subtle.
Makes me wonder if one of my cancer of unknown origin cases might have been a cholangio one day.
No, I mean, they're super subtle. I mean, this one is super subtle. I guess yeah. Anyway, so this is just a scary case that I felt like sharing with everybody, so everybody can be scared.
One thing I've learned is these livers, they take different forms and shapes and sizes. So without scrolling through the whole thing and seeing every corner of the liver, I really don't let them go. That's the lesson I've learned by looking at these scary cases.
Okay, so the next case is pretty cool. Not for the patient, of course. This was a young man in his 20s. And this was the original study. I'm showing you the original study. I already looked at the follow-up. You can see this is a very kind of aggressive looking mass. You notice that centrally you have all this, kind of ill-defined areas of decreased signal, and notice that there is signal loss again on the second echo, indicating that there's some either iron or hemosiderin, concentration in this area, probably because of prior hemorrhage. This is the T2 of this mass. Very, very kind of ugly looking mass, pretty much occupies part of most of the right hepatic lobe for this patient. Notice that the liver is, very smooth contour. The remainder of the liver looks pretty normal. So this was the notice on the the mass has some intrinsic kind of T1 brightness. Again, a lot of this central part is very hypointense, and if you kind of subtly notice that there's like periphery of rim, so that's hemosiderin deposition, and of course the mass avidly enhances. The central areas remain hypoenhancing, and these are the two, portal venous undulate images, and notice that there's really no washout, right? Especially inferiorly, kind of like blends in. So this is the unicorn, really. This is, any guesses?
Would this be an angiosarcoma?
I mean, yeah, I guess it could be.
Can you show the T2 again, please?
Let's see if I can bring up the diffusion. And of course there's diffusion. So it's a very ugly looking, obviously not a benign mass in a young person with no underlying liver disease.
Fibrolamellar, Victoria?
Right. So this is a unicorn of a fibrolamellar. I mean, I've seen several fibrolamellar HCCs like in actual patients. And this is the first time that I see that it actually follows, you know how ABR likes to ask questions about, central scars of fibrolamellar and compare and contrast them with those of FNH. And to be honest, this is the first time that I see fibrolamellar that actually has this T2 hypointense central thing that can be, called a scar. So this is just a very, kind of, board, this tumor read, the ABR questions and kind of follows all the things that, ABR uses in the questions for fibrolamellar. So this is a very aggressive tumor, happens in young patients, without underlying liver disease. And again, I've seen maybe 4, 5 over the course of the year in real life, and they never look like that. They usually just look like, non-specific, kind of ill-defined, aggressive masses. So anyway, so that was a very interesting example of what these tumors theoretically typically look like. But these tumors are very, very uncommon. I think that's all I got for today.
Have you seen multiple fibrolamellar HCCs?
In one person?
Yeah,
No,
in the liver.
no. I've only solitary.
Solitary.
Yeah.
I'll do one companion case next time.
This case it's just a nice review of like cystic pancreatic lesion. So here, the patient that we've been following for just multiple different cystic lesions throughout the pancreas, and the largest one is probably this one at the pancreatic head, and it's been stable over time. And I'm showing this case. Came across this paper, which I thought was really, really great. Sort of using the morphologic features of the cystic lesions to classify them into, sort of generally MCNs, serous adenomas versus IPMNs. And so this group, they kind of stratified the lesions into sort of these broad categories. So you've got like the cystic, and then you have the lobulated lesions, and then you have these cysts, but this one has septation, and it's just like a kind of a, I guess what Arthi would call an encapsulated lesion. And then you have pleomorphic, and then the clubbed like. So when they stratified the oligocystic serous adenomas versus MCNs versus IPMNs, like this patient, I think probably had the club-like form of this description. So this type, when you look at the club-like finger-like lesions, you know, almost, and this is a small sample, but almost all of it, all the lesions were IPMNs. The lesions to be, of course, more concerned about are the mucinous cyst adenomas. And so those lesions usually had that encapsulated look. It's a unilocular cyst, and then, you know, with septations within it. The lobulated ones are typically like either oligocystic or IPMNs. So I thought this was a great paper and describing the different subtypes and how you can use these morphologic features to be very specific about what you think the diagnosis is. That's it.
Does anyone else have cases to share? If not, then I can share the few that I have. I chose a theme today, and that is GYN and maybe one OB case. Let me just bring it up. All right. So I'm going to start with this 57-year-old lady who had a hysterectomy in the past, and she presented with dull, achy pelvic pain. You know, sure enough, she gets an ultrasound first. There is, initially, the techs didn't know that she had a hysterectomy. And so this structure that they saw in the pelvis was labeled as the uterus with thickened endometrium and an endometrial mass. And then once they got the history that the uterus itself is absent, then they realized, and she had undergone an oophorectomy as well. And then they realized that this is in the right adnexa, and this is a complex adnexal mass. So as I scroll through it, it almost seems like in the wall there is some vascularity, but the central portion is tubular and does not show any vascularity. So, you know, this was called a right adnexal mass. And given her age, they were concerned about an ovarian malignancy. And so she underwent kind of a staging CT to look at the whole abdomen pelvis. Scrolling on this axial contrast enhanced CT. Here is what we see in the pelvis. Any thoughts? Okay, this is going to help you.
Is that retained tube that's dilated or something? Because
That's a good thought. And then in the coronal, I'm going to show you there's some calcification here. And if I trace this.
Christine says mucocele.
Yes, indeed. Actually, if you trace it back, it goes all the way to the cecum. And this is one of the largest mucoceles that I've ever seen. It's huge. You know? So this turned out to be an appendiceal mucocele.
I mean, that wall looks a little thick, and I wonder if there's also adenocarinoma that's kind of sitting in there somewhere.
That's a great thought. Like this area here.
Yeah, and there's like
window. There's almost like some enhancing soft tissue here.
Mm-hmm.
When it came out, it was just a simple mucocele. This didn't pan out. Perhaps, you know, we don't have a non-con, so maybe these are some. Clearly, this is chronic, long-standing. So maybe some proteinaceous debris or some inspissated material there. And it's amazing that it didn't rupture. You know, I've seen mucoceles ruptured at a smaller size, or maybe they grew large and ruptured, but it's just impressive to me how this huge thing is still intact. And I hear your point. There is some soft tissue thickening in this region as well, like right here. But I just thought it was interesting that they caught this transvaginally. And, you know, this is one of the things I thought I should keep in my mind when we see tubular dilated cystic structures, in addition to, as Victoria rightly pointed out, a retained hydrosalpinx. In addition to that, maybe this would be another rare differential. And then just to reiterate, mucocele is just a colloquial term, and it's often, you know, this term is ambiguous. It doesn't exactly signify what the pathology might be. It's best utilized to describe an imaging appearance. And there are non-neoplastic mucoceles, and ideally they should be called appendiceal mucinous lesions. So non-neoplastic and neoplastic. And then the non-neoplastic ones are the simple mucoceles or retention cysts filled with mucus due to obstruction of any underlying etiology, whereas the neoplastic ones have been classified by WHO into low-grade appendiceal mucinous neoplasms, or LAMNs, and HAMNs, so high-grade appendiceal mucinous neoplasms. And then the last one, of course, is adenocarcinoma, as you said, Nelly, mucinous adenocarcinoma of the appendix. So that's one. And then moving on, let me just quickly get rid of the markers here. So this is a young lady who presented with rectal pressure and pain. And I'm going to scroll through the sagittal T2 weighted images here: anteverted uterus, bladder. Here is the rectum, anal canal. And as I scroll through, you see a T2 hypointense or mixed signal mass, which, let me, okay. This is what it looks like in the axial plane, axial T2s. Again, there is a component that is hypointense. This is a lobulated cystic lesion. This is the pre-contrast T1 weighted image. And by now, there must be some ideas of what this might be.
Do you have the diffusion?
Yes. This is the DWI, high B value, and here are the ADC maps.
How old is she?
She's 50. The diffusions are a little tricky. Don't let the diffusions throw you off. You know, because the pre-contrast T1 itself has intrinsic T1 bright signal within it. I'm going to show you the subtraction images, and this is what it looks like on the subtraction. There was no solid enhancing component to it. But I think the trick to recognizing what this lesion might be is the location. So this is the sacrum here, coccyx, tip of the coccyx, and this is behind the rectum.
There's no fat, but
Yes, Steve
Tailgut
said,
cyst.
indeed, yes, you're absolutely right, Steve. Tailgut cyst. And, you know, one of the, like the look of this lesion, when I looked at it, I was like, oh, this looks like an endometrioma. But because of blood products within it, intrinsic T1 bright signal, either blood products or mucinous contents. And then because of the location, rightly, you know, we narrowed it down to a tailgut cyst. I've not commonly seen endometriomas in this location. And of course, the lady didn't have any other evidence of endometriosis either. But tailgut cyst is, based on the location, is a great look for this lesion. And just something to remember is these are hamartomas that develop from vestigial remnants of the foregut, basically. And they have a strong female predilection, middle-aged females. And really their presentation, although they are cystic lesions, their presentation can be very variable. They can bleed, they can have proteinaceous or mucinous contents within them and give rise to this multiloculated varying signal mass. So that's the second one I had to share. And then I have one more. Yeah, this is a cute show and tell. Okay. So she is 30, pregnant, incidentally found to have this adnexal lesion.
yikes.
And again, as we scroll through axial T2, this This is the T2 non-fat sat. And here it is. Some motion degradation, as we can expect with a moving baby on these pregnant patient MRIs. Of course, no contrast, no gadolinium contrast given. And I'm going to show you the T1 contrast.
cute meconium. Did you see that?
I know. Liver, meconium, super cute. And here we go. So some intrinsic T1 bright signal within this. Any thoughts? Oh yeah, Rupa says large dermoid. Indeed, sometimes these adnexal masses in pregnancy can be really challenging, but this one was a relatively straightforward one with components of fat within it, proteinaceous material, fat, and without, so it was good because, without having to give contrast, this as such on the non-contrast didn't show any worrisome features, and it came out only after she delivered. There was no requirement to operate on her in the second trimester. Having said that, we've been tricked once where a patient had bilateral adnexal masses and we couldn't give gadolinium contrast, but one looked like a dermoid. For some reason, they went in, perhaps the patient didn't want to wait, and it turned out to be a seromucinous tumor, which had a dermoid component within it. So I still find these large adnexal masses in pregnant patients on a non-contrast MRI can sometimes be challenging. All right, and then I have one last case to share. All right, so this is a 33-year-old lady post C-section presenting with pelvic pain. And so she had this contrast enhanced CT. She has a couple of fibroids in the uterus. Here is the bladder. And then you see a hematoma sitting right here. And on the sagittal view, this is where the hematoma is located. So this is just a show and tell, for us to look at what a bladder flap hematoma is, when do you intervene or worry about these, and to distinguish it from sub-fascial hematomas. So this is basically a bladder flap hematoma. Apparently, these are very common in patients with C-section, and it is considered normal to have a bladder flap hematoma that measures less than 4 centimeters. Typically, nothing is done about them. But if they are large, then that is cause for concern and intervention. And these are classically, as they are not within the wall of the bladder, they're just in the location between the dome of the bladder and the lower uterine segment. And that's because the peritoneum is incised here, reflected down to access the uterine content, the baby. And these typically develop in this location. And when large, earlier they had to go in and operate and evacuate, but now based on the degree of liquefaction, we can drain them percutaneously. Like we can offer the patient an IR option as well. And then this should be distinguished from sub-fascial hematoma, which is a hematoma that is extraperitoneal and which arises from bleeding from the inferior epigastric vessels. So basically, bladder flap hematomas are located here, whereas these are the inferior epigastric vessels on either side. And if these bleed, they can cause a hematoma in the space of Retzius or in the anterior like in the prevesical space. And these are to be distinguished from bladder flap only because the approach, the surgical evacuation approach is different. For one, they need to go through the peritoneum, and the other is extraperitoneal completely.
Anu,
Yes.
why would we want to drain a hematoma if it's not infected?
No, if it's infected, then you can drain it.
Okay.
But if it is large for pressure, for pressure symptoms, you can drain it as well. Yeah, it's large in size. But it also depends on the degree of liquefaction, right? Commonly, we don't drain hematomas. That's kind of the golden rule. Yeah, that's that.
We as in radiology community, or we as in our division?
Our division definitely.
Our division
support.
drains
Support.
everything.
I don't know what the other places do, but we don't typically support draining or leaving drains in a non-infected hematoma. Yeah. Yeah, these are the 4. That's my GYN theme for today. I'm going to stop sharing. And
I have a prostate case. If no one else have cases. Can you see my screen?
yes.
Okay. So this was a patient who had this on. Patient had PSA level of 4. But actually, I'm sorry, that was post-treatment. Pre-treatment is 50. And they got an MR. Patient came in with known Gleason 8 prostate cancer, and this was done for staging. So this is kind of, this is sort of like the prostate MR that you want to read every day. There's this beautiful, it's prostate cancer is usually multifocal. So this is kind of unusual in several ways. Is number one, it's a single lesion, and it's very restricting, and it's just kind of it's great when you see this case, but we don't see these cases very often. And the path actually turned out to be really interesting. So this was what was, so then the patient was very high risk for recurrence, after any treatment actually, based on the nomograms. And so our urologist went ahead and just gave, 1 dose of Lupron, ADT, before the planned surgery. And this is what happened after the 1 dose of Lupron. It was remarkable, just the response. So the tumor shrank from 2 cc's to 0.5 cc's.
Can I
Yes.
interrupt you for a minute? Steve
Yes.
has a question. He says,
Oh, sorry, what's the question?
it looks like the man never had a biopsy or prostatitis, but you mentioned path. So did he get a biopsy after this MRI?
The biopsy was done before the MRI. The MRI was done for staging.
Was it a systematic biopsy or was it directed to this lesion?
It was not a fusion biopsy. I mean, a systematic biopsy would get this very easily.
Do you have pre-contrast T1 on this patient?
Yes. Let me find it for you.
Sometimes I find hemorrhage can fool you. Of course, here there are other features as well, but just on T2.
It's ISO, I think. Yeah, here it is.
Okay, so this is a true lesion.
Mm-hmm.
Okay.
So anyways, we went, the patient was able to tolerate only 1 dose of Lupron. And they, this is what happened. It's like a phenomenal response. PSA went to 4 from 50. And then the patient had a radical prostatectomy and, did very well. Like he's NED right now. His PSA is undetectable. On pathology, this turned out to be ductal adenocarcinoma. I mean, ductal is ductal variant. And so we had a really informative discussion because I thought ductal was usually around the urethra, central. And this was not. This is in the peripheral lesion. So our pathologist said, well, actually, even though most are in the central gland, a minority can present in the peripheral gland, like this case. And the unique thing about ductal is they're considered to be incredibly aggressive, in contrast to conventional prostate cancer. So this patient has a very high chance of recurrence and progression, even though he's currently clinically no evidence of disease. And as I mentioned, this was kind of unusual because prostate cancers usually don't look like this, right? They're usually multifocal. They're not as obvious. They don't look the way this does. And I guess that was the case because this is not the usual variant. This is a ductal variant, the more aggressive variant of prostate cancers.
So Nelly, what are the, in addition to Lupron, where else, or they're just gonna let him be since nothing will work?
Yeah, so we had a pretty extensive discussion about what to do because now it's known, now that we know the pathology is ductal. And so, well, the decision was if the patient is doing clinically okay, right? Their patient had severe symptoms on Lupron and couldn't tolerate it, like beyond one dose. And so, you know, to then treat this patient without symptoms or PSA recurrence, it would just be hard to justify and to convince the patient, right, to continue ADT. So the decision was made to just watch and wait until we either have PSA elevation or, you know, something else that would then warrant treatment. But having a very honest discussion about, you know, prognosis.
Gotcha. And he's not eligible for resection?
Oh no, he got resection.
Oh, you
So
did?
yeah. Sorry. So after the resection, we got patient got the radical prostatectomy and is NED right now.
Got it.
Yeah.
Makes sense.
I have another prostate case. Do we want to wait until next time, or is there somebody else that have cases to show?
Get on.
I don't see anybody typing in, so you could go ahead.
Okay. Can you see my screen?
Yep.
Great. So this patient has Gleason 6, known Gleason 6 prostate cancer. PSA is 6. And 6 and rising. So it was 5 and now it's 6. And so this was you know, we did an MR. The patient had a biopsy before at an outside facility, at a systematic where they found the Gleason 6. And after that biopsy, you know, 4 or 5 months ago, prior to this MR, patient had urosepsis from the biopsy. It was treated, it was fine. And then this was the follow-up after the biopsy 4 or 5 months later, because PSAs continuing to climb. So what do you guys think about this?
Wait, this is after biopsy?
This is 4 months later. If anybody's chatting in, I don't, could it be, oh, okay, so yes, so
Right, so
Varun,
abscess maybe, or a localized infection.
yeah, exactly, right? This is,
T2.
we're looking, yes, T2 bright, is that what you said?
Yeah.
Yeah, so this is right, exactly, right? This is not a typical, I mean, the Gleason 6 was in this region in the left mid gland. So there's probably, you know, background cancer, but it would be very hard to say because we have this T2 hyperintense and it was restricting, right? And it's, let me show you the post-con. Oh, this is not good. Here, this one's better. I hope this one's better.
Was he symptomatic for it though?
No, completely asymptomatic. So this was unexpected findings on MR, but it, you know, it doesn't here. It's like a nice perilesional enhancement. So yeah, so this is what we think is a case of a prostate abscess, and it's probably aseptic because the patient doesn't have any symptoms and there's no leukocytosis. That's kind of contained itself. So the patient is getting treated with antibiotics and we'll get a repeat imaging once that's done, and then be counseled for definitive treatment with prostatectomy.
Yeah, I'm curious, like if he is asymptomatic, aseptic abscess, why would we give him antibiotics, right? And plus, if it's so well walled off, would they even reach that area? So maybe just aspirating it transrectally.
So we talked about that. So the plan was to do the original plan, this was just for the staging because they, patient wanted to get it treated with radical prostatectomy. So this was just to see if there's extracapsular extension and whatnot. And this was a surprise finding. So the urologist was concerned because of inflammatory changes that would make the surgery challenging. And they didn't want to aspirate it because they didn't want to kind of muck around with that area and make it worse. And so the thought was, if it is an abscess and it looks like an abscess, then maybe treat it with antibiotics first, let it cool down so that it doesn't complicate the prostatectomy.
Yeah, interesting thought process.
Yeah.
Awesome. Thank you so much. Any other cases? Any other interesting things to share?
One more thing, sorry, the reason this was kind of unusual because the abscess, like this was 4 months later, right? So I mean, if it was, a couple weeks later, then I would be, it's like fine, makes sense. But this is like 4 months later, and I didn't realize you can harbor such things for so long, and be just clinically fine. So this was kind of atypical in a few ways. Yeah.
Yeah. We'll wait for the follow-up from you, and then they repeat post antibiotics to see if
Definitely.
at all or not. Should we stop here if there are no more cases? It's 2:57.
Sounds great. Thanks, everyone.
Thanks, everyone.
Thanks, everyone. Thanks, Anna, for hosting.
Thank you.